you look very smart. A lot of people have this, including a lot of residents, and when you tell them what they have, it's like, wow. But what the oral allergy syndrome is when you eat pitted fruits, your mouth itches and you get swelling. And it's not fruit allergy, it's allergy to birch. So you have seasonal allergies, and when you eat pitted fruits, you get itching, and you've got to avoid them. If you eat them cooked, you do fine. So apple pie is fine, raw apple, problematic. You can also get this with melons if you have ragweed allergy. But again, sort of a strange disorder. If you know about it, you look smart. If you don't know about it, you scratch your head and say, this is a bit crazy. And then respiratory reactions, which I'll go into. So I'm going to just say a couple of words about urticaria before we get into the details of food allergy. Acute urticaria is acute onset hives. It's of short duration, less than 6 weeks. The vast majority of cases in young children are due to viral infections. So with urticaria, we always worry about food reactions and other things. And really, infections are the most common etiology for this. If it's a food allergy, you know it. The families come in and they tell you what it was. They gave them peanut butter for the first time and the hives broke out right afterwards. When it's due to foods, it's due to a very small number of foods. It usually occurs within minutes. So acute reactions to foods, medications, minutes later the symptoms come out. It can be up to 2 hours. It's extremely rare beyond there. And even 2 hours is sort of a stretch, and you scratch your head and question whether there's something else going on. It's often accompanied by angioedema. Angioedema is the same as urticaria. It's just what level in the skin is involved, but the underlying process is exactly the same. The angioedema can take longer to resolve, though. It takes a while for that fluid to resorb. It can be associated with GI or respiratory symptoms in anaphylaxis. If it's an IgE-mediated reaction to food, you can diagnose it based on skin testing. Any patient with acute urticaria with the food must be considered at risk for future anaphylaxis and needs to be evaluated appropriately. In contrast, chronic urticaria are hives lasting for greater than 6 weeks. There are a lot of these patients out there. Most of these cases are idiopathic. It's only about 10 to 15% where you can identify an underlying etiology. We now know that up to 40% of these patients have an autoimmune problem. They develop autoantibodies to their IgE receptors on their mast cells. Rarely are these caused by food reactions or even environmental allergies. So patients with hives that last this long, in the vast majority, it doesn't make a whole lot of sense to evaluate them by typical allergy testing. I see a lot of them evaluating for underlying systemic disorders and making sure that they're on effective treatments. But typical allergy testing is not particularly fruitful in these patients. A quick word on atopic dermatitis that ties in with food allergies. So I think you've probably had a talk on atopic dermatitis already. It's chronic, extremely pruritic inflammatory skin disorder. In very young children, it involves the face typically. As they get older, over 2 years of age, the popliteal antecubital fossa. In adults, the hands and necks are most commonly involved. It's extremely pruritic. It's, in the severe cases, quality of life is dramatically affected. It usually begins in early childhood, more than 90% of cases in the first 5 years of life. And the incidence is about 5 to 15% of children. Again, much more common in young children, but certainly I have a lot of adolescents with very severe atopic dermatitis. So what is the role of food allergy in eczema? And this comes up all the time. Every child with eczema, the families are concerned, what is it that's causing this? And in children with severe atopic dermatitis, and I'm talking severe, they're breaking their skin open, it's extensive, 40 to 50% of children may have food allergy as a triggering event. So 40 to 50%. 5 foods, again, constitute the majority of the reactions in these patients. It's not sort of the unusual foods that they've been given. With less severe eczema, it's only about 30% that have food allergy that plays a role. And this is important. How do you treat eczema? You go over skin care. It's in the patients that are more severe and that are refractory to standard therapy that food allergy really comes into the thinking. And the problem is if you test all of these patients with bad eczema for food allergy, you always come up with positives, and they're mostly false positives. So you want to think about this as you approach it. Treatment, The most important thing, skin hydration. Bathe frequently, 10-15 minutes, plain water. They get out, blot the skin dry, and you put on a good emollient, something greasy or something creamy. You're locking in the moisture because the problem is their skin does not have a good barrier. It does not hold in water well. There are patients like one I saw yesterday that have had bad eczema for a year. Just by putting them on regular baths and good emollients, their eczema gets much better. For kids that have significant inflammation, you treat with topical anti-inflammatories. So topical steroids have been around for decades. You use them judiciously. You base the strength on the severity and also the age of the child. Very young children, you don't want to go to the very high doses. In older children, I treat them with whatever they need to be treated with to get the inflammation under control. There are also the non-steroid anti-inflammatories, pimecrolimus, tacrolimus, which are now have a black box warning associated with them, but they're still effective for things such as eyelid dermatitis, where it's very difficult to treat with steroids, and it works very well as long as you're aware of the concerns with them and are upfront with the families about where that information comes from. You want to control nonspecific irritants, so every child with eczema is exacerbated in the summertime when it's hot and they're sweaty. They're also exacerbated when they get viral infections. Their immune system becomes active, including in the skin. You want to control secondary infection. Most of these patients are colonized with Staph aureus. If they become super infected, their eczema goes out of control. And it's based on the patient. A lot of excoriations, give them topical mupirocin. Patients that are particularly severe, you can use bleach baths, mimicking a swimming pool to decrease colonization. And then allergen avoidance plays a role in a subset of these patients. It's not every patient that needs to avoid food allergens. It's in that subset that's severe, refractory to standard therapy, and that have been thoroughly evaluated. But you don't want to give broad restrictions on these children that already have a terrible disease. So you want to think about these things very carefully. Eosinophilic gastroenteritis, and I include in here, and I apologize that it's not listed separately, but eosinophilic esophagitis is the other disorder. What are these disorders? You get a lot of eosinophils, a lot of eosinophils with inflammation in the esophagus or other parts of the gastrointestinal tract. Symptoms can include abdominal pain, vomiting, reflux, diarrhea, and weight loss or failure to thrive, depending on the age. Those that have involvement of the esophagus can present with dysphagia when they get to teenage years. When they're adults, it's not infrequent to have food impactions, that they have such tight strictures that food becomes impacted and they need to have it removed surgically. Most of the patients with these disorders are atopic. About 70% of patients with eosinophilic inflammation with eosinophils have underlying atopy. 75% of them are also males, so it's much more common in males when it's the esophagus than in females. The food allergy is found in about 50% of these patients, and frequently when it's found, it's to multiple foods by testing. We don't understand the underlying problem here. It's not necessarily strictly an IgE-mediated, the things you test for on skin testing. There may be cell-mediated components. Multiple foods are often implicated, making it very difficult to manage. And if you put all these patients with eosinophilic involvement on elemental formulas, 99% of them get better. If it involves other parts of the gastrointestinal tract, success rate is lower. But it's not particularly compatible long-term to be on elemental formulas. So with these patients, we're trying to identify specific food allergens that may play a role. You can treat them with topical steroids where you take Flovent and you don't use a spacer, you shake it and put it in the mouth, spray it and swallow it, and don't drink or eat for 30 minutes afterwards. And in severe cases, you can use systemic steroids that are effective for all eosinophilic disorders. Eosinophils melt away with steroids, but again, not particularly compatible long-term. So these are problematic patients, patients with bad allergic disease that have reflux-type symptoms that don't get better with standard therapy. You got to think about these things. Send them to the gastroenterologist. Have them undergo endoscopy and biopsy because you don't pick it up otherwise. And these disorders are much more common than people think. In adults, they go undiagnosed and continue to go undiagnosed. What other syndromes do you have? So respiratory reactions. respiratory reactions to foods are common in the setting of anaphylaxis.